Good evening, everyone, and welcome to today's wonderful evening. Archana, Dr. Vinita, Vanilla, and Shweta. Can you be able to? Uh, you can unmute your mics, Doctor. No problem. Whenever you're answering. Hi, Vinita.
Good evening, sir.
Good evening. And Shweta. Hi, Shweta.
Hello, sir.
Hi. And Archana, are you audible? You're there, Archana? Archana, you can unmute your mic. And Vanilla, are you there?
Yes, sir. Good evening.
Very good, very good. Thank you all for joining this wonderful evening. And let's make a opportunity to study together every day. And studying alone is boring. Similarly, PowerPoints, presentations, videos, even that is also very boring. Today, the modern world is all about audio, so that we meet, we discuss, and we get an opportunity to be able to do a good revision. So that's the whole plan. So let us make the great beginning, Doctor. I keep asking you questions, you keep answering the questions. That is how we do the revision of almost 100 points, right? Now, let's start with general medicine. Tell me, what is this disorder I'm talking about? A middle-aged woman presented with a progressive jaundice, pruritus, fat-soluble vitamin deficiencies. There is a significant rise of alkaline phosphatase. Also, there is a rise of the bilirubin and rise of cholesterol, and her anti-mitochondrial antibody is positive. If this clinical unit is given in the exam, what will be your answer? Vanilla, Archana, Shweta, Vinita, any of you can be able to answer? Yeah. Punch your answer, doctor. A middle-aged female, jaundice, pruritus, anti-mitochondrial antibody positive, alkaline phosphatase is elevated, and increase in cholesterol, fat-soluble vitamin deficiency. All this will make you to think about what is your possible diagnosis. Yes, doctor. Even the online students on the YouTube, you can be able to punch your answers. Yes, Vanilla.
Liver-related disease.
What is that?
Liver disorder.
We know that it is a liver disorder, but what is that autoimmune disorder where anti-mitochondrial antibody is positive?
A primary biliary cholangitis, sir.
Absolutely right, Shweta. Wonderful. So, typically in primary biliary cirrhosis, we have a middle-aged woman presenting with pruritus with anti-mitochondrial positive, right? Now, Shweta, what do you think is the treatment of primary biliary cirrhosis? Especially, what is the drug if you give that will bring down the bile salt levels, cholesterol levels, and slow the progression of the disease? Anybody would like to try and answer? I'm waiting for your answer. Ursodeoxycholic acid. It is known to slow the progression of the disease. For the pruritus, we give cholestyramine, but for the primary biliary cirrhosis, mainly the treatment would be to do the liver transplantation, is what you need to remember. All right. Now, I'm going to quickly give 5 points about hemochromatosis, and then once more I'm going to ask you the question so that you can be able to revise. So hemochromatosis is, all of you know, iron overload state. So where does the hemosiderin accumulate? Liver, pancreas, heart, adrenals, testis, even pituitary. And primary hemochromatosis is, it is an autosomal recessive disorder, HFE gene mutation, lot of iron become absorbed, the dietary iron. These are the points to remember. And any condition like sickle cell disease or alpha thalassemia, where you are giving a lot of transfusion therapy, secondary hemochromatosis occur. So what will be the clinical presentation of hemochromatosis? One of the favorite questions of the examiner. There can be abdominal pain, diabetes, hypogonadism. Why hypogonadism? Because the iron overload will affect the pituitary, and pituitary does not produce LH and FSH. Because of that, testosterone production affects in the testis. That is the reason the hypogonadism of the hemochromatosis is called hypogonadotropic hypogonadism. Hypogonadotropic, that is FSH LH is low, and hypogonadism, that means testosterone is low. It is not hypergonadotropic hypogonadism. So where will you get hypergonadotropic hypogonadism? That is high FSH LH with a low testosterone. Where do you get that? You get it in conditions wherever problem is at the level of the testis. Here the problem is not at the level of the testis, it is the problem at the level of the pituitary. That is the reason the hypogonadism of the hemochromatosis is called hypogonadotropic hypogonadism. That is what you need to remember. Then another favorite question is arthropathy in hemochromatosis. Which joints are involved? Metacarpophalangeal joints are involved. That's what you should remember. Similarly, hemochromatosis can lead to hemosiderin deposition in the heart, and that can lead to heart failure. It can lead to impotence. It can lead to cirrhosis. These are all the things with hemochromatosis. Similarly, bronze skin pigmentation, cardiac dysfunction, they're all the classical findings. But one thing you should remember about hemochromatosis is liver is involved, heart is involved, but lung is not involved, kidney is not involved, eye is not involved. A lot of times examiner will try to ask you this question. Then another very interesting combination of findings you should not forget in hemochromatosis. How is serum iron? Increased. How is percentage saturation? Increased. How is ferritin? Increased. Whenever, generally, if you look at ferritin generally increases when the iron is low, like in iron deficiency anemia. But how do you know that a high ferritin is not due to iron deficiency but because of hemochromatosis? A high iron with a high ferritin, the combination you find only in hemochromatosis. Similarly, serum transferrin, hemochromatosis, examiner will tempt you in the tomorrow's exam. Decreased, not increased. Similarly, the transferrin saturation. How do you get transferrin saturation? Serum iron divided by TIBC, total iron binding capacity, will give you transferrin saturation. It is more than 45%. It is more than 45%. That's what you need to basically remember. Then how do you diagnose? Is one of the favorite questions of the examiner. You have to do a liver biopsy. You need to look for the hepatic iron index. That's how you diagnose hemochromatosis. And how do you treat? Weekly phlebotomy. For how long? Every 2 to 4 months. Maintenance. And what are the iron chelating agents? Deferoxamine, defiripone, defersidox. They are the ones which are used. And what are the complications of hemochromatosis? There can be cirrhosis, there can be hepatocellular carcinoma, there can be restrictive cardiomyopathy, arrhythmias, diabetes, impotence, arthropathy, hypopituitarism. These are the things that you need to basically remember. Now, are you ready, doctor? I'm going to ask you questions. Are you ready? You took a lot of points from my mind. Now, quickly tell me, Shweta, what is the cause of secondary hemochromatosis? Shweta, you're there? What are the causes of secondary hemochromatosis? Archana, Vanilla, anybody can answer? Yeah. Am I audible? Am I audible?
So hepatitis.
Yeah. So, what are the causes of secondary hemochromatosis?
Hep C.
Huh?
Hepatitis C, sir.
No, secondary hemochromatosis. Just now we discussed now. Anything that need chronic transfusion, like sickle cell disease and alpha thalassemia. Now, see, first I revise you about 10 points. After that, I will try to ask questions in the same topic. That's the plan. Okay. Now, hemochromatosis involves which joints? Who is going to give me answer? Shweta, Vanilla.
MCP.
Metacarpophalangeal.
Very good. Very good. And how is ferritin? How is serum iron in hemochromatosis?
Both are
Serum iron, ferritin, and percentage saturation all are increased.
Very good. And how is serum transferrin?
Transferrin is decreased.
Very good. And what is meant by transferrin saturation?
serum iron by TI, total iron binding capacity, sir.
Very good. And what is the value of this transferrin saturation, which is suggestive of iron overload?
45%, more than 45%.
Okay.
In hemoglobin.
Is my voice clear?
Actually, it's in my area, the internet is not connected.
Good. Okay.
So it's cracking up on me.
But, yeah, but otherwise my voice is audible. Can the online students can punch?
Yes, sir.
In the YouTube? Yeah.
Yes, sir.
My voice is clear, right?
Yes, sir.
Okay. And TIBC more than, the transferrin saturation more than 45% is diagnostic of iron overload. All right. So how do you make a diagnosis of hemochromatosis? Archana, Vanilla, and Sweta.
Biopsy for confirmation.
By?
Hepatic index.
You do liver biopsy to look for the hepatic iron index. Similarly, MRI can help you, and also HFP gene mutation is also done. Now, what type of hypogonadism is hemochromatosis? Is it hypotrophic hypogonadism or hypertrophic? Is it hypergonadotropic hypogonadism or hypogonadotropic hypogonadism?
Hypogonadotropic hypogonadism.
Very good, very good, very good. And how do you treat hemochromatosis?
Phlebotomy.
Very good.
Weekly, iron chelating agent.
Very good. Can you tell me a few iron chelating agents?
Deferoxamine, deferiprone.
Very good. Deferone and deferiprone and deferoxamine. Very good, very good. So this is generally in entrance exam. These are the 5-6 points you need to have tips when you go to the exam, right? Now, let us talk 10 points about Wilson's disease. Now, first thing, the age group of Wilson. First of all, what is the inheritance? Autosomal recessive. What is the problem? Defective copper transport, and that accumulates and deposits all the copper in the liver and brain. That is the whole problem of the Wilson's disease. Then how does the patient, what is the age group? Less than 30 years, and 50% becomes symptomatic by age 15. All right. Now, what is the history? Wilson's presents to a gastroenterologist because of hepatitis and cirrhosis. Wilson's is associated with ataxia and tremor. So a neurologist may first time discover. Wilson's typically can take the patient to psychiatrist. Psychosis, anxiety, mania, depression, anything can be presenting feature. In Wilson's, we find Kaiser-Fischler rings, all of you know. But what is the entrance exam question? Which layer is this deposition of copper in Kaiser-Fischler? Descemet's membrane is the layer where you have the deposition of the copper is what you need to remember. Very good. Good to see Ashish Jain, who is on the YouTube. Ashish, you can also do one thing. You can directly join into this broadcast. In the description, there is a place where I give you the StreamYard link. So if you click on this StreamYard link, you can join the conversation. Okay, I'm going to paste it. Yeah. So if you click on this, you can join the conversation. Anytime in the middle, if you have joined, of course, you can participate through the YouTube chat, but here you can even be vocal and it will be interesting when you join, right? So, yeah. Good to see Archana back. Now, yeah, let us take up the next question. Next point. Kaiser-Fischler ring deposition is in Descemet's membrane. Then the next common point that is asked in the exam is how is serum ceruloplasmin? Serum ceruloplasmin is decreased. Serum ceruloplasmin is decreased. And how is urinary copper? Urinary copper, 24-hour urinary copper excretion, if you check, it is increased. And liver biopsy is the diagnosis. And how do you treat Wilson? Penicillamine is one of the most important drugs that you need to remember. And a lot of times if the patient has a liver dysfunction, you can't use penicillamine. So there, trientine hydrochloride, trientine, T-R-I-E-N-T-I-N-E, trientine hydrochloride is preferred if there is already liver dysfunction in a patient of Wilson's. Otherwise, you can use penicillamine. So these are copper chelators, penicillamine and trientine, and they typically will lead to the increase in urinary copper excretion, basically. Then you need to do dietary copper restriction. So now what are the foods where copper is very high? Shellfish, liver, legumes. So there copper is high, you need to restrict, you need to avoid. And you also give zinc in the treatment of Wilson because zinc will increase the excretion of the copper, fecal excretion. So that is all the story about Wilson's. The 10 points you need to remember for the tomorrow's exam. Now, are you ready for a fight? I'm going to ask you the same in the form of questions. Are you ready? Yeah. What are the common clinical presenting features of Wilson's? Archana, Vendela, Shweta.
So
What
it
are
can
the
be
common?
ataxia.
Very good.
Hepatitis, cirrhosis,
Very good.
Case of flexure ring.
Good.
psychiatric symptoms,
Very good. And in Kager Fisker rings, where does the deposition occur?
basement membrane of cornea,
Very good. Is it rigidity or spasticity? What do you see in Wilson? Should. Rigidity or spasticity? What do you see in Wilson? Rigidity is a sign of extrapyramidal and spasticity is a sign of pyramidal. So you see rigidity, not spasticity,
Rigidity.
right? Because it goes and deposits in basal ganglia and all. What you find is rigidity, not spasticity. How will be serum ceruloplasmin levels in Wilson?
decrease,
So they decrease, celluloplasmin
Very good.
levels decrease.
Urinary copper excretion?
increase,
It increases 24 hours copper excretion. Urine.
Very good. And what are the two copper chelators we use?
uh, penicillamine,
Penicillamine and triantine.
Triantine. Very good. And what are the foods where copper is excessive so that we should avoid them in Wilson?
legumes,
Legumes and shellfish.
liver, shellfish,
And liver.
Nuts.
Legumes, liver, and shellfish. And what is the trace element you administer to increase the fecal excretion of copper?
zinc,
Very good. And what is the common age group of Wilson?
So can you repeat the question?
30,
Less than 30
35
years.
years.
And 50% are symptomatic by age 15.
50.
And what type of inheritance pattern is Wilson?
Autosomal recessive.
Autosomal.
Very good, very good. So that completes us two clinical conditions. Now let us go to the third condition. 4 to 5 points about it, let us discuss. There is a hypoglycemia in the patient. There is a Whipple's triad. Now tell me, what is that condition I'm talking about? Where do you see Whipple's triad? Come on, Vanilla, Archana, Shweta. So, in insulinoma, there is a documented hypoglycemia, number one. Number two, symptoms of hypoglycemia like sweating, palpitations, anxiety, tremors, headache, confusion. Similarly, if you give glucose, the symptoms resolve, right? So this is called Whipple's triad of insulinoma. And why do you get insulinoma? I mean, where do you get insulinoma in any syndrome? Yes, sir. Men syndrome, multiple endocrine neoplasia. Shweta, did you hear about men type 1, type 2, type 2B? You've heard of it, right? Shweta, you're there? Archana, Shweta, Vanilla, and many more who are all online. So, very good. Ashish Jain is answering from online YouTube. Ashish, also please, you can directly click on the Extremia link which I sent. Then you can join this room along with us. Okay. So every day evening, 6 o'clock, we have a live class. We discuss around 100 points for the exam. And it is like chai pe charcha. We all sit together and do the discussion. Okay. Now, Whipple's triad. So, is typically seen in insulinoma. Men type 2, men type 1, you find insulinoma. Then, what are the laboratory findings in insulinoma? Fasting serum insulin. Fasting. Normally, if you are fasting, insulin is supposed to become suppressed. When we are fasting, normally when we are fasting, our glucose is low, then insulin is low. But in these people, fasting serum insulin is elevated, which is a classical feature. Similarly, how do you know that all this high serum insulin is because of insulinoma? There is one very important clue. Good to see Sham also joining. Very good, Sham, for joining late but latest arrival. Sham, good evening. How are you? So, Sham, you are there. You can unmute your mic, Sham. You can kindly unmute your mic. Unmute mic. Yeah. So, Sham, there is an unmute button. Kindly unmute your mic. Okay? Yeah. Now, fasting serum insulin is elevated. Similarly, C-peptide level is elevated. Every time insulin is produced from the proinsulin divides into C-peptide and insulin, and C-peptide level is elevated. Vanilla, is my voice clear?
Yes, sir. It's clear, sir.
Absolutely. Thank you. So, next. What is the definitive test? Okay, there is hypoglycemia, there are symptoms of hypoglycemia, and if you make the patient drink a little glucon D, and he is becoming better, all is fine. But how do you make a definitive diagnosis of insulinoma? So basically, 72 hours fasting is a definitive test. After prolonged fast, patient goes into symptomatic hypoglycemia. Once hypoglycemia is there, get the serum insulin. Normally, if hypoglycemia is there, serum insulin should be low. But in these people, there is hypoglycemia, but at the same time, the serum insulin levels are elevated in spite of hypoglycemia. That is the clue. Similarly, C-peptide levels are elevated. Then that's the reason 72 hours fasting, and after fasting, checking for the serum insulin levels is the most important thing to make a diagnosis of insulinoma. Similarly, you also look for the ketone bodies. Serum beta hydroxybutyrate levels will be very low, and generally always remember, no insulin, high ketones. High insulin, no ketones. That is the reason in this patient with hypoglycemia, with a very high insulin levels, normally hypoglycemia patients typically, if the hypoglycemia is because of high insulin will be high, hypoglycemia will be low. Glucose will be low. But generally, if you fast, if your glucose comes down, that is the time where insulin should be suppressed. But if it is not suppressed, means you should think of insulinoma, is what you need to remember. So C-peptide is elevated. Serum beta hydroxybutyrate, ketone bodies are low. Because insulin is high, ketone bodies will be low. Serum cortisol will be normal or elevated. Normally, if you have hypoglycemia, you expect a low cortisol. A hyperglycemia, you expect a high cortisol. But here, In spite of hypoglycemia, cortisol will be either normal or elevated. That is another clue to say it is insulinoma. Then how do you localize the tumor? You do transabdominal ultrasound, CT scan, MRI, endoscopic ultrasound, and also there's a very important test called selective arterial calcium stimulation test. What is it called? Selective arterial calcium stimulation test. Typically, that will help you to localize the tumor. And treatment is surgery, resect the insulinoma. All right. Now, Shweta, Archana, Vennela, and everybody. Good to see Dr. Shyam. Hello, Dr. Shyam. How are you?
Good evening, sir.
Yeah, wonderful, wonderful. Shyam, you are from which college, doctor?
Sir, Deen Dayal Upadhyay.
Very good. Deen Dayal Upadhyay. Thanks for joining our combined study program. Every day we will sit together, no PowerPoint, no monitor, no screens. And we sit, take up a topic, pick up some points about each topic. We do revision, and once more we will ask you questions on the same topic and you need to answer. So this is our style. So in this style, we run every day evening at 6 o'clock. Please don't forget to join this session. If you want to join, you need to have the StreamYard link. If you want the StreamYard link, you please connect with our helpline. Okay, so that is the whole plan. Okay, guys, are you ready? I'm going to start punching you with questions. Which men syndrome do you find insulinoma? Come on, what's your answer? Which men type you find insulinoma? Come on, the great guys. What is your answer? Vennela, Shweta, Archana, Shyam. Is it men type 1, type
Men.
2?
Type 1.
Very
Type
good.
1, sir.
Very good, very good. And Shweta, Vennela, Shyam, Archana. What is Whipple's triad? Who is going to tell me the 3 symptoms? 3 things. Whipple's triad. What do you have in Whipple's triad, doctor? Come on, punch your answer. What do you have in Whipple's triad? Yeah. Who is going to give me the answer? Am I audible, Vanilla?
Yes, sir. Audible.
Yeah, what is Whipple's triad?
Hypoglycemia
Very good.
and
Hypoglycemia.
relief of
Very good.
hypoglycemia with
Symptoms of
administration of insulin.
hypoglycemia, then excellent. Resolution of the symptoms with the correction of hypoglycemia is what you need to remember. Good, 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 good. Now, what are the laboratory findings? If you do fasting serum insulin, how will it be? Vanilla, Shweta, what is your answer? Yeah.
Elevated.
Yes, doctor.
Fasting serum insulin is elevated, sir.
Very good. How is C-peptide levels?
C-peptide levels are also elevated.
Very good. And how will be serum cortisol levels?
Cortisol levels are increased or normal.
How will you localize the insulinoma?
Ultrasound.
Very good.
Yeah, ultrasound, MRI.
Is there any biochemical test you want to do? Selective
Arterial calcium
stimulation.
calcium stimulation.
So how do you treat my insulinoma, doctor? How do you treat my insulinoma? Will you give radiotherapy, chemotherapy, or will you
Surgery,
surgery? Surgery
resection.
is considered to be the treatment. Very good. So that is all the story, doctor. Right? Now, the next topic we are going to discuss is, now you tell me, watery diarrhea, dehydration, muscle weakness, flushing, a highly malignant tumor which is producing this. And it is a secretory diarrhea with a low stool osmotic gap. Patient also has echlorohydria. Can you tell me what is the condition I am talking about? Any guess? Watery diarrhea?
Syndrome.
It is? Punch your answer.
Carcinoid.
Syndrome.
It is Vipoma, VIP producing tumor. Vasoactive intestinal polypeptide producing tumor. Barabar? So, Vipoma is highly malignant. There will be watery diarrhea, dehydration, muscle weakness, flushing, low stool osmotic gap. That is the reason it is called secretory diarrhea. High VIP levels. There will be echlorohydria because a high VIP levels of Vipoma, a high VIP inhibits the gastrin production. If the gastrin is not there, that leads to echlorohydria. So that is the reason you find echlorohydria. Vipoma, VIP, also lead to hyperglycemia, hypercalcemia, hypokalemia. And how do you diagnose? You do CT scan to localize the tumor. You do surgery to remove the Vipoma. And Vipoma have a significant watery diarrhea, dehydration. So replace fluids, replace electrolyte loss because they have significant hypokalemia. And one of the ways to treat Vipoma is by giving the octreotide. Octreotide is known to lead to suppression of the VIP, vasoactive intestinal polypeptide. Now, doctor, let's take up a quick revision. Who is going to answer me? You need to answer. Archana, you are not answering. You have to answer, right? Okay. What type of diarrhea you get in Vipoma, Archana? Is it secretory, osmotic? Punch your answer. Come on, speak your answer. Vanilla, Shweta, anybody? Yeah, who is going to give me the correct answer? Yeah. So, in Vipoma, what happened? What type of diarrhea? Vanilla?
Secretory diarrhea.
Very good. And how will be stool osmotic gap?
Low stool osmotic gaps.
Very good. And how is calcium level and potassium levels? In Vipoma?
Calcium levels are increased. And there is hypokalemia.
Very good. And very good. And is there any drug that will decrease the production of the VIP?
Octreotide.
Very good, very good. And surgery is the treatment. So that is all the story of Vipoma. Next, the next topic that we are going to discuss, 10 points about Pancreatic cancer. Now, let us start. See, if you are having PowerPoints, all these things, they're all distractions. Similarly, video is a distraction. Audio means like Ekalavya with Dronacharya. You will be fully focusing and remembering for the tomorrow's exam. Okay? That is the reason I made this an audio only session. Alright? So now, 10 points I'm going to tell you about pancreatic cancer. I'm going to ask you the questions. 75% of pancreatic cancers are all adenocarcinomas. They in the head of the pancreas. What are the risk factors? Smoking, yes. Chronic pancreatitis, yes. Any first degree relative who has pancreatic cancer, risk factors. It's more common in men and it occurs after the age 45. How does a pancreatic cancer present? It's a cancer in the belly. So you have abdominal pain, obstructive jaundice, loss of appetite, weight loss, weakness, fatigue, indigestion, etc. A lot of times, pancreatic cancer patients are all asymptomatic. By the time the disease worsens, they reach late, that is the time they present. Peculiarly, sometimes depression, psychological depression can be the most prominent symptom of pancreatic cancer. Then what is Karvoiser's sign in pancreatic cancer? Palpable, non-tender gallbladder. Palpable, non-tender gallbladder is the hallmark of pancreatic cancer, is what you need to remember. See, why this is important is, even cholecystitis also can present with similar symptoms. But any cholecystitis lead to a shrunken gallbladder, tender gallbladder. But if it is pancreatic cancer, gallbladder become non-tender and palpable, which is called Karvoiser sign. Similarly, there is a migratory thrombophlebitis in case of pancreatic cancer. And that is called migratory thrombophlebitis. That's called Trousseau sign, is what you need to remember. So these are the few points you need to have in mind. Now, what is the tumor marker of pancreatic cancer? CA19-9. CA19-9. And CT scan with contrast. That is the initial test. It will help you to localize the pancreatic cancer, know the local invasion, know about the distant metastasis, etc. So, if the mass is not visualized on CT, you have done CT with contrast, but if you are not able to see, then you can use endoscopic ultrasound. Endoscopic ultrasound with or without ERCP is considered to be the diagnostic hallmark. So how do you treat pancreatic cancer? Kisi ko ho gaya, how are you going to treat? If it is locally advanced or if it is metastatic, it is the most frequent presentation. Palliative chemotherapy is what you do. But if it is a small tumor in the pancreatic head, no metastasis or no major vessel involvement, lucky if the patient comes so early. Because a lot of times this will be very asymptomatic, pancreatic cancer. You do chemotherapy, you will be doing Whipple's procedure What is Whipple's procedure? Remove pancreas, remove duodenum. Pancreaticoduodenectomy is called Whipple. That is done if it is a small tumor in the pancreatic head with no metastasis or major vessel involvement. Then, chemotherapy with 5-fluorouracil and gemcitabine. It can improve the short-term survival, but long-term prognosis is poor. And ERCP with stenting to relieve the obstructive symptoms caused. Typically, patients will with jaundice, so obstructive symptoms. So you do ERCP and do stenting. That is a part of the treatment. Is what you need to remember. Come on, doctor. 10 points. I'm going to fire the bullets back to you, and you are going to give me the answers. If you don't speak, I'll be disappointed. Okay? Now, what is the type of histology most of the times in pancreatic cancer? Shweta, vanilla.
Adenocarcinoma.
Excellent. What is the location most commonly for pancreatic cancer?
Head of
Head of the
pancreas.
pancreas.
Tell me quickly what are the risk factors?
Smoking.
Obesity, first degree relatives.
First degree relative having cancer. Chronic pancreas.
Excellent.
Alcohol consumption.
Chronic pancreatitis can occur because of alcohol. So, yeah. Then, what is Carboyzer sign?
Palpable,
non-tender
bladder can cell is
Very good. And what is Proteus sign in pancreatic cancer? Proteus sign in pancreatic malignancy. It's a migratory thrombophlebitis, which is considered the Proteus sign, right? Now, my next question would be, what is the initial diagnostic test in pancreatic cancer?
contrast enhanced
endoscopic
ultrasound.
CT scan with contrast, initial test. And if you don't see on CT, then endoscopic ultrasound with
Endoscopic ultrasound.
Yeah. Then what is the tumor marker?
CA 19.9.
CA 19.
19.9. Okay. Now, what is the common presentation? Will it be locally advanced or metastatic or small tumor with no metastasis? Which is more frequent?
Locally advanced with metastatic.
Locally advanced.
Or metastatic, right? And if it is a small tumor in pancreatic head, no metastasis or major vessel involvement, what will you do?
Whipple's procedure.
Very good. And what is Whipple's procedure?
Pancreaticoduodenectomy.
Very good. And what are the two chemotherapeutic agents you'll remember?
Gemcitabine,
5-fluorouracil.
Very good. And if there are obstructive symptoms, is there any palliative way you can treat?
ERCP stenting.
Stenting with ERCP.
Excellent. So, whenever you read a book, you will forget. But whenever you discuss like this, you will not forget. All right? So, do you like this way of learning? What's your opinion, Shweta, Vanilla, Archana?
Yes, sir.
Yeah. Generally, after the PG entrance is over, we will go into a kind of a depression. Oh my God, so many mistakes we did and all that. We'll be thinking how to read, who is our company and all. You should never worry like that because Dr. Murali Bharadwaz is your company until you get the seat. Every day evening, either me or one of our other faculty who are the NEET PG toppers, etc., they will spend 1 hour doing revision with you, asking you questions, making you to revise. So this 1 hour should stimulate you to read the next 23 hours until the tomorrow's class. And I like to see all of you in every day's class. Now, Doctor, before we close the session, let us quickly take up another another one more topic before we call it a day, right? You still have energy for one more topic?
Yes, sir.
Yeah.
Yes, sir.
Now, paroxysmal nocturnal hemoglobinuria is the next topic that you need to remember. Just 5 points you need to remember. So what happens in paroxysmal nocturnal hemoglobinuria? There is a deficiency of one molecule called GP1 anchor molecule. GP1 anchor molecule. And what is the general purpose of this GP1 anchor molecule? It will keep CD55, CD59 proteins attached to the red blood cell. So, if this CD59 is attached to the red blood cell, that red blood cell is protected from the complement mediated hemolysis. complement आके आरबीसी को ब्रेक करने का तरसते हुए देखता है आरबीसी की तरफ. But RBC is being protected. RBC's big brother is there, CD55, CD59, to protect the RBC. RBC is like a younger sister. CD55, 59 is an elder sister. Complement is like the villain in the movie, waiting to attack. And between this younger sister, RBC, and elder brother, CD55, 59, there is another brother in the middle called GP1 anchor molecule. So he is the one who keeps them together, and all the three will be going to the college. And our villain, complement, is waiting. So in the people who have PNH, there's a deficiency of this GP1 anchor molecule. If it is not there, then CD55, 59 cannot attach to the RBC. If it is not attached, then RBC is destroyed by the complement. So when the RBC is destroyed by the complement, then there will be anemia. There is hemoglobinuria, so dark urine. Then very important thing, PNH is a prothrombotic state. It leads to venous thrombosis. Venous thrombosis, like hepatic vein thrombosis leading to Budd-Chiari syndrome, etc. So they present with abdominal pain. So how do you diagnose paroxysmal nocturnal hemoglobinuria? You do the flow cytometry and check for the CD55, 59, and you will demonstrate the absence of CD55, 59. Now, doctor, let me check how much you retained and ready to face an exam. Now, my first question, PNH is deficiency of what?
GP1 anchor molecule.
GP1 anchor molecule.
Beautiful, beautiful. Very happy to see Archana speaking. Now, what are the CD markers?
CD55 and CD59. 55 and 59.
Very good. That's how you should become competitive every day. Tomorrow, more and more number of answers you should give. Now, how will the presenting features? What are the presenting features of PNH?
Anemia,
Hemoglobinuria.
dark colored urine.
Very good.
Prothrombotic.
So there is anemia, dark urine, and venous thrombosis. And what are the most accurate diagnostic tests?
Flow
Flow
cytometry.
cytometry.
And what do you look for?
CD55 and 59 deficiency.
59 division.
Very good. And what kind? Is it auto-antibody mediated like hemolysis or complement mediated like hemolysis?
Complement mediated hemolysis.
Absolutely. So that is what 4 or 5 points, doctor. Every topic 4 or 5 points later. hai. Every entrance exam you go, they will only twist and turn those 4 or 5 crucial points. All right. Now, still before we leave this wonderful evening, because Archana is giving wonderful answers, I am encouraged to pick up another topic and 5 to 6 points. All right. Are you ready?
Yes, sir.
Yeah.
Yes, sir.
Polycythemias. Polycythemia. Let us talk about it. So, how do you diagnose polycythemia? Hematocrit is elevated classically, and hyperviscosity will be there in the blood, due to which patients will develop thrombosis. Also, patients of polycythemia present with intense pruritus. Why? Because polycythemia is a problem at the level of the bone marrow. So not only RBC cell lines, erythroid precursors are hyperproliferative, even basophils are also excessively produced. Basophils release histamine, histamine lead to pruritus. Typically, what type of pruritus it is called? Aquagenic pruritus in polycythemia vera. That means patient takes a shower and that leads to pruritus. And all that thrombosis will lead to blurring of vision, neurological deficits. And one side you get thrombosis, at the same time other side patients will also have bleeding, bruising, etc. etc. Then always before you diagnose polycythemia rubra vera, you should rule out secondary polycythemias. So what is the meaning of secondary polycythemias? Whenever there is any hypoxia in the body, that also lead to polycythemia, that's called secondary. But without any hypoxia, if there is erythroid hyperplasia in the bone marrow and that increases the hematocrit, then you call it as polycythemia rubra vera, is what you should remember. So what is polycythemia rubra vera? In that case, not due to hypoxia. It is the clonal proliferation of pluripotent marrow stem cells in the bone marrow. The pluripotent stem cells, they become excessively proliferative. Normally, if there is a hypoxia that stimulates erythropoietin, erythropoietin will go and stimulate bone marrow to produce more erythroid precursor. That is normal. That is secondary polycythemia. But there is no hypoxia, but there is a clonal proliferation of the pluripotent marrow stem cells. That is called polycythemia rubra vera. That is the reason to diagnose polycythemia rubra vera. What is important? First, rule out there is no secondary. That means there is no hypoxia. So how do you rule out? Get a ABG, get a PaO2 levels, check for the lung disease, take history whether he is a smoker, whether he lived in a high altitude like Nepal or in Ladakh or Leh, or look for anything that is leading to hypoxia. So once you rule out all that, then only consider polycythemia rubra vera. And why there is a clonal proliferation? JAK2 mutation, JAK2 mutation. That is what you need to basically remember. And some patients, so what is the best initial test of rubra vera? Elevated RBCs, elevated WBCs, elevated platelets, all three cell lines. And ABG will be normal. That is important. And erythropoietin levels are suppressed. Suppose it is a secondary polycythemia due to hypoxia, high EPO levels. But polycythemia rubra vera, because of clonal proliferation, then EPO levels will be typically low, normal oxygen, and the hematocrit more than 60%. So this combination makes you to think about polycythemia rubra vera. So what is the most accurate test? JAK2 mutation. And there is an entity called relative erythrocytosis. Suppose the patient is hypovolemic or diuresis if you are giving a lot of diuretics, or if there is any loose motions, gastroenteritis, I am dehydrated. So dehydrated person also will have a high hematocrit. But that is not polycythemia. It's called relative erythrocytosis. So this is what you need to remember. And how do you treat polycythemia rubra vera? You have to do phlebotomy. If you give aspirin, all that painful thrombosis, pain relief will be there. And you need to bring down, because it's a clonal stem cell proliferation now, you have to bring down the levels. So for that, you need to give hydroxyurea. Interferon is a treatment. Come on, doctor. Are you all ready for taking up my questions? Yes?
Yes.
Now, what is the presentation of polycythemia? Vanilla, Archana, Shweta.
Intense pruritus,
Very good.
bleeding,
Yeah,
blurring of vision,
very good. Thrombosis.
thrombosis,
Hepatosplenic. Next. What is the mutation in polycythemia rubra vera? What is the
JAK2
mutation?
mutation.
JAK2 mutation,
JAK2 mutation.
Very good, very good. And is it only RBCs or anything else derivative?
WBC and platelet
everything.
also.
WBC platelets are
Obviously,
also
WBC
elevated.
platelets all are
Very
elevated.
good. Then how are the erythropoietin levels in polycythemia
Decreased,
rubra?
Suppressed, decreased,
Very good. And how is oxygen?
normal,
normal,
Very good. And
normal.
hematocrit more than how
Oxygen
much?
saturation normal.
Very
And
good. Hematocrit
60%.
more than how much?
60%. 60%.
Very good.
60%.
Very good. What are the two drugs that reduce the cell count?
Interferon,
Very
hydroxyurea,
good.
Hydroxyurea,
Very good. And tell me two, three conditions where you find relative erythrocytosis.
dehydration,
dehydration,
Hypovolemia, diuresis, gastroenteritis, burns, etc. etc. All right. So thank you very much for joining this wonderful evening, and we will meet every day evening. And please do come. And good luck. Enjoy the preparation. Enjoy the journey. Study every day. Have 3 to 4 good friends, and that is how the journey of postgraduate entrance. It is never painful. It is not at all painful. It is very benign. It is enjoyable, provided you are in the middle of good company. And let me assure you, with Dr. Murali Bharadwaz, you are in the company, a good company, and every day we will all study together. Good luck. And please go back to the Incus app. There's a lot of videos, a lot of question bank, a lot of quiz tournaments, a lot of flashcards. Please do practice and then get better. Thank you.
Thank you, sir.